one of the things that continue to frustrate me as a pathologist is how pathologists are allowed to deceive the public, saying that only certain pathologists are qualified to interpret certain tissue, human tissue pathology. And as I can get it in focus, it's going to go out of focus from time to time. But every now and then, this is a bone marrow that I took from an autopsy. The person had been dead for over 3 days. And I just want to show you, just as I scan around, how beautiful the histology is preserved as I continue to go around, just to give you the start of just how much bone marrow tissue we have in this scraping of the rib sample from an autopsy case. Look how beautiful. This is in a relatively young person, so the cellularity is estimated at about 80%, but we'll talk more about that as I show you just how valuable autopsy bone marrows. So over my near now 30 years of practicing pathology, and I've been chief director, chief lab pathologist, chief of lab pathologist, chief director anyway of lab pathologists, reviewing thousands of not only bone marrows, but also flow cytometry examination and other hematology report, peripheral smear reviews, and so forth and so on. So I'm going to go down just on this example here. This is a reactive bone marrow in a person who died from pneumocystis pneumonia. But I want to kind of go down just to kind of highlight some of the salient features that we often see with reactive bone marrows. If I can stay in it, now it's not going to stay in focus always, but I may run out of video. But the first thing we do, obviously, we've assessed cellularity. The next thing is to look at evidence of, I'm going to go to another video because I'm losing this video. So after assessing cellularity, we look at to make sure that there's myeloid elements, myeloid and erythroid and megakaryocytic elements in this bone marrow. In this example, when you see clusters of megakaryocytes, you immediately think about erythroid and megakaryocytic hyperplasia. And in fact, that's what this bone marrow showed, basically. So it was slightly cellular, hypercellular, not that bad, but just a slightly hypercellular. Maybe it's really closer to normal cellular because this is a young person. But what we're looking at, you can see some plasma cells, but you see this erythroid. A lot of what look to be lymphocytes, those are probably, there may be some lymphocytes in there as well, but most of those are erythroid precursors. And I was going to scan around to show you when you see clusters of megakaryocytes, which you don't tend to see, that support a diagnosis of megakaryocytic hyperplasia and erythroid hyperplasia. These are all early myeloid cells, but there is no cancer in this bone marrow, and there is no myeloma in this bone marrow. There are some reactive plasmacytosis and lymphocytosis, but nothing, because this person, again, had end-stage pneumocystis disease. You see those clustered? That's like 3 or 4 megakaryocytes in the field. That's a sign of megakaryocytic hyperplasia. Thank you for listening to the video.